So what are the risk factors for this hospital-acquired pneumonia? For the hospital-acquired pneumonia, it can be in elderly people or an atypical age, immunocompromised patients with postoperative lung failure or postoperative multi-organ failure, especially when there is a base lateral ectasis of the lung, or you have an increased duration of mechanical ventilation, or you are a patient with some structural lung disease, then you are at a risk prone for developing your hospital-acquired pneumonia. Then what happens when do you get this multi-drug resistant ventilator-associated pneumonia? So this is more or less seen in patients who have been in intravenous antibiotic for 30 to 90 days. So this is a little broader term because your IDSA defines it as 30 days, your CDC defines it as 90 days. So broader term of 30 to 90 days, there has been a usage of intravenous antibiotics. There has been septic shock at the time of VAP. There is an ARDS which has preceding the VAP, or more than 48 hours of hospitalization, or the patient is on renal replacement therapy. So these factors are predominantly for development of multi-drug resistant VAP. And what is the pathogenesis of development of VAP? Earlier, it was believed that it is mostly your microaspiration of your oropharyngeal secretions. And based on this pathophysiology of oropharyngeal secretions, we had early VAP and late VAP. Early VAP was considered the VAP which develops in the first 3 to 5 days after initiation of 48 hours of mechanical ventilation, and late VAP was around 5 to 10 days. So why they made this differentiation of early VAP and late VAP was they believed that the MDR organisms or the gram-negative or a very fulminant organisms occurred only in the late VAP phase, wherein you get the secretions from your GI tract because of the translocation of the bacteria. And in an earlier VAP, you had only the microaspiration of your oropharyngeal secretions. But then later it was realized that if you segregate it into early VAP and late VAP, then probably the attempt to initiate or target a multi-drug resistant organism gets delayed, which results in increased mortality and morbidity. Hence, this early VAP, late VAP concept went away from existence. And so, one pathophysiology is definitely your aspiration of oropharyngeal secretions. And there is an impaired mucociliary clearance of the respiratory secretions, obviously. Underlying disease severity of the patient, malnutrition, cancerous patient, poorly controlled diabetes, patient on steroids, definitely they are prone for a bad virulent organisms. Obviously, endotracheal intubation because you're bypassing your protective nasal tract, your oral tract, your salivary secretions and other things, and you're getting a dry gas. There is no humidification which is happening, or it can be as simple as hematogenous dissemination from other sites. It could be a blood culture related infection, it could be a pyelonephritis which is coming, or you have an abscess, or you have an abdominal infection, or it could be inhalation of aerosols or inhalation of aerosols like you have from cross infection from one patient to another patient, or it could be a bacterial translocation from the gut.